Fine. So let me just download these images. So downloading, don't know what's going on there. Download. Okay, so we are now looking at, let's do this one. Go from the top. So again, it's abdominal pain. Let's think about what phase of image this is. Okay, so we're coming down, we've got a small hiatal hernia. Yeah, a bit of hiatal hernia, but probably not causing abdominal pain. It doesn't look like it's compromised in any way. And most of the stomach is actually sitting below it. I'll be careful about calling any abnormalities within the region of this region over here, because generally speaking, get a bit of folding of the stomach. I've seen a lot of people call tumors and all sorts of things there. I've got a very high threshold for calling anything in the stomach, and I think that's probably the safest way to go, because depending on what they've eaten, not eaten, how hydrated they are, etc., the stomach can look all sorts of weird. So I wouldn't go too far into it. Then you've got your aorta, which is sitting over here. Aorta is on the left, and you can see that looks kind of bright, but not as bright as the bone. And then when you actually look at the portal venous system over there, that looks slightly brighter. So therefore, this must be a portal venous system image. So then as you scroll through, you can see that there are some cholecystectomy clips. So they've had previous surgery, no cholecystectomy clips, any intrahepatic duct dilatation. So you can see a little bit of this low density adjacent to the vessels. And that's what I'm talking about when you're looking for intrahepatic duct dilatation. But it's much more obvious when you've got true pathology that's going on here. It's a little subtle, but that's going to be because we know that this patient had a previous cholecystectomy. So we're not worried about this particular biliary tract per se. Right, so now as we scroll through, the kidneys, they look okay. They don't look like they're obstructed at all. The pancreas, is feathery looking thing at the front, looks normal. Spleen looks okay. There's not a trauma scan, so we're not looking at anything that we're particularly worried about with regards to trauma. So let's go down to this region over here. One of the things I always do is just make sure there's no hernias, because that could be an easy slam dunk diagnosis, but no hernias on this particular situation. So now we're going to do a bit of legwork. We've really got to get stuck in and look at the bowel. So let's follow, and we can see that kind of zigzagging thing over there. And coming up to this region, you can see that looks a bit fecally loaded. And actually, if you look at the fat around it, it looks very, very abnormal, right? And you're coming up to here, coming up to here. And it doesn't seem to be focally located within a particular diverticulum, because it can be quite tempting to call this diverticulitis, couldn't it? Because what you've got is essentially multiple diverticula, but you don't really have a focal diverticulum that's causing any sort of clear inflammation, but you do have what looks like a little bit of fluid around there, a little bit of fluid around there, a little bit of fat stranding around there as well. And as we kind of follow the rest of the bowel, we're going upwards across for the sigmoid colon, then into the left iliac fossa, coming all the way up again, coming up to the splenic flexure, going across the transverse colon. Let's go transverse colon. Come on, go all the way across now, all the way across. That looks okay. All the way down, all the way down. And so we're sitting somewhere in the region of the cecal pole, and everything looks okay. In the small bowel, if we do one sort of cursory look through it, the small bowel looks okay as well. So as you kind of scroll through now, hopefully you can see that, man, there is a difference, isn't there, around the fat. So fat, all looks okay. Get to here, it looks very, very hazy. So if this is not diverticulitis, if I'm saying it's not diverticulitis, then what could it be? So what's actually can happen to patients, usually if they are elderly or someone said something, yeah, perfect, well done. Exactly right. So you picked it up, you know your stuff. So this is exactly what you said, Stercoral Colitis. So what can happen is that the fecal impaction, lots of feces just sitting there, can actually start resulting in inflammation itself. It starts to cause something called Stercoral Colitis. And Stercoral Colitis, where you've got impacted feces within the colonic lumen, and there's subsequent inflammation. And the interesting thing about this is that you could have someone that's got a defunctioned large bowel, and you can still end up having this, because you end up you can end up getting some material being produced within the region of the bowel, within the colon anyway, because you've still got secretions happening, still got some impaction of secretions. And as time goes on, that can get really impacted, can get calcified, can get hard, and then they can end up having inflammation of bowel that's not even in use anymore over a long period of time. So it's quite a useful diagnosis to be aware of when it doesn't quite conform to, I say, ischemia, diverticulitis, appendicitis, epiploic appendicitis. When you really think about it, this particular image doesn't conform to any of those things. But there is definitely something wrong, and that's what it is. It's called Stercoral Colitis. Right.
So yeah. In the chat, Imran.
Oh yeah. Yeah, they said I've answered that. Oh yeah, there's a Stercoral Colitis, and I've said that's true. So I'm going to say I'll answer that live. Done. So Fine. So yeah, well done. Whoever's picked that up, very good. Let's go to the next case.